This is a pear-shaped structure like this, and you all know this is a gallbladder where you have the fundus here, and this region is the neck of the gallbladder. Now remember, the gallbladder is black. Why? Because it has bile inside it. So any fluid on ultrasound is black. Now fluid here inside the vessel, which is IVC, is also black because obviously there is blood inside. Now portal vein is this structure here. Remember, when you see the gallbladder, identify the neck region, and there you would see a parallel sort of lines, which is the common hepatic duct or common bile duct, CBD, common bile duct. So you see this tiny black line like this is the common bile duct, and it is very much parallel or line anterior to the portal vein. So how do you identify CBD? First, look for the neck region. Why? Because the neck has the cystic duct, and the cystic duct attaches to the common hepatic duct, and where the common hepatic duct it attaches distally, it is called as the common bile duct. Remember your anatomy? The cystic duct attaches to the common hepatic duct, and then it forms the common bile duct. So you will find the common bile duct very much near to the neck of the gallbladder. So how to identify it? Try to identify the portal vein. So once you identify the portal vein, this is the common bile duct. You see a very small structure like this. This is how it normally is. Usually it's not measuring more than 4 or 5 millimeter in diameter. So if you measure from this part to this part, it should not be more than 4 or 5 millimeter in diameter. Now when it becomes dilated, what does this mean? Obstruction. It means that the bile is being obstructed. So the patient would be jaundiced. Okay? So common bile duct obstruction means there is also intrahepatic duct dilatation. So how does that appear on ultrasound? This is how it appears. You see, the ducts get dilated like this. You have a double duct appearance. So the portal vein is dying, and above the portal vein, the common bile duct is also dilated. So you will have a double duct appearance. Again, this is black. Why? Because the bile or the fluid is black. Now, if you do the CT scan on this patient, you will see that these black structures are the ducts which are dilated. Now, why it is black on CT? Because it didn't take up contrast. What is this structure here? Portal vein. As I've told you, the portal vein would take up contrast. Why? Because it's a vascular structure. So once you give contrast, you see there is contrast given. You can see contrast in the aorta. So this means this structure here is the portal vein. So these structures are the ducts which are dilated, and obviously the bile inside would not take up contrast.
Why is double here in the ultrasound?
Why is what?
The other one.
This is the duct, this is the portal vein. So this is the double duct sign. Okay? But on CT, it would appear something like this. You see, these are the left hepatic ducts, these are the right hepatic ducts, and they both join here to form the common hepatic duct. And then the common hepatic duct is joined by the cystic duct from the gallbladder, and then it continues as the common bile duct. Okay?
So on the left picture, the lower duct is the...
This is the portal vein, this is the common bile duct. Very much similar to this. Now, little bit about the pancreas. You see, the pancreas lies like this. You see, it is lying horizontally or slightly obliquely in the body. So this region is the head of the pancreas. This is the body of the pancreas, and this is the tail of the pancreas. If you cannot make out, this is the head of the pancreas, this is the body of the pancreas, and this is the tail of the pancreas. How would you identify pancreas? First, try to identify the portal vein. And this is the splenic vein. So where the splenic vein comes and communicates with the portal vein, this is known as the splenoportal confluence. So try to identify these vascular structures. The structure that is immediately anterior to these is the pancreas. So this, if you identify the portal vein, try to figure out where the splenic vein comes and joins the portal vein, and the pancreas would be lying just anterior to it. Very much similar to this. This is the diagram. I've labeled it for you. So all structures that are here are labeled here. This is the region. This is all. The white is the pancreas. This is the portal vein. This is the splenic vein joining the portal vein. This structure here is the artery, which is superior mesenteric artery. Okay. This is the aorta,
This one, sir.
this is the IVC, and this is the gallbladder. Clear on this?
Yes.
So this is how it appears on ultrasound. Now the problem with ultrasound is, if it is a thin lean patient, you would have a picture like this. But if it is an obese or patient, or you have a lot of gases in the abdomen, you will not get a good picture like this. So this is the limitation of ultrasound. In obese patients, because of the fat and the gas in the abdomen, sometimes you are not able to see the entire pancreas. But if it's a thin patient without gaseous distension, then the pancreas is very much visible, and you would have a very nice picture of the pancreas on ultrasound. What is this structure here? In the region of the head, the common bile duct. You see, this is the common bile duct. So this is the common bile duct in the pancreas, in the region of the pancreatic head. Yes.
You mentioned something about a confluence on the...
Confluence means joining of two things together. So this portal vein here, this is the portal vein. You see, I've labeled it for you. So this is being joined by the splenic vein. So this is splenic vein coming and opening into the portal vein. So where the splenic vein comes and opens into the portal vein, that confluence or joining part is known as splenoportal confluence. Okay. Now again, pear-shaped structure with fluid inside, but it is different from that gallbladder. Why? Because now you see a stone inside. Now the stone is appearing white, but behind the stone there is this shadow. Why do you have the shadow? The sound waves are unable to go through the stone because it's a hard structure. So the sound waves are reflected back. So they don't actually go through the stone. So that is why you have this black shadowing here behind the stone. So we call this as shadowing behind the stone. This tells you that the sound waves are unable to go through the stone. Now look at this gallbladder and compare it with this gallbladder. How is it different?
Air fluid level.
There's a fluid level, good. And there's a stone here again, so you see the shadowing.
Thickened.
The
But-
wall is thickened.
The wall is thickened, very nice. So you see the thickened wall. Compare this nice wall here with this thickened wall here. Compare this thickened wall here. So the wall is thick and edematous.
That's
And
why-
what is this inside the gallbladder? The bile. Okay, this black is the bile, but this one is not the bile. This is bile. So what is this?
Pus.
Debris or pus inside. Okay. So this one is inflamed gallbladder. So what signs are there? You would see that the fluid inside, that the bile is not clear bile. It's debrinous bile. The walls are thickened, as you can see here. The wall is thickened. This is not normal wall. The wall is edematous and thickened. So inflamed wall. And you would obviously sometimes see stones associated with this. So this is a picture of acute cholecystitis. So inflamed gallbladder. Okay. By the way, if this acute cholecystitis settles over a period of time, you know, these patients keep on having attacks of cholecystitis. Then there is fibrosis developing inside the wall, and with a period of time, the gallbladder wall gets shrunken. So in chronic cholecystitis, you would see the wall collapse because of fibrosis, and all that you see is stone inside. So if you see just stone shadows inside the gallbladder, it is chronic cholecystitis. In acutely inflamed gallbladder, there will be distension and there would be edema of the wall of the gallbladder.
This white thing in the right picture is a stone or what?
This one is a stone, this one is also a stone. Both are gallbladder stones. The problem with this gallbladder is it is acutely inflamed. This one is a normal gallbladder with a stone. We have all the other signs. You see the wall is thickened, the gallbladder is distended, you see there is debris inside. So these are all signs. Sometimes you will also see pericholecystic fluid. You see some fluid around the gallbladder. So these are all signs of acutely inflamed gallbladder. Now, if you do a CT on the same patient, if there is a stone inside, this is how the gallbladder looks like. You see the stone line and the gallbladder around it. Very nice wall all around. Now compare this gallbladder with this gallbladder. How do you see, what difference does it have from this and this? You see there is a stone inside. This bile is not normal looking black bile that you have here. So again there is debris inside. And if you look at the wall again, this wall is thickened. Compare it with this wall. Very nice sharp outline of the wall. And what about this wall? Thickened again. So this is a case of acute cholecystitis. Now compare this gallbladder with this gallbladder now. What is the difference?
Thinner
There's
wall.
a
Thinner wall.
white line.
Abscess.
Calcification is here, calcification is also here. What else?
Atrophy.
Abscess.
Shrunken. Smaller.
Is there any difference other than this?
No,
Liver, who said liver?
liver is smaller.
What about the liver?
Yes.
And then
It's
the
a
darker.
big change in color.
Yes, go ahead. How is the liver different?
Shrunk.
You see, there is something in the liver. You see? Compare this liver here with this liver here in the fundal region. So this liver is not normal. You see this liver?
Fibrosis.
It's adjacent to the gallbladder fundal region. This is acute cholecystitis. This is gallbladder cancer. You see, the tumor, when it starts from the gallbladder, it has to invade something. And what is the adjacent structure which it can invade? Liver. The gallbladder fossa is just adjacent to the liver. So it has to invade something. So if the liver is adjacent to it, it will invade the liver. This is how the gallbladder cancer looks like.
Doctor, what's in the
This one?
what's the white thing in the gallbladder?
This one? Stone.
Stone?
Yeah, this one is stone again. These stones are different stones compared to this. Why? Because these have more cholesterol in them. You understand? Gallstones have more cholesterol element. So the density varies.
You will not be sure that's the first one is part of the liver unless you know the level of the image, right? Like if it's the liver or
This is the liver.
I mean
So this is the gallbladder.
how could you be sure like this is called the liver itself?
No, this appearance is a gallbladder. Why? Because it has fluid inside. It's a pear-shaped structure. The location is the liver. It's hanging just below the liver. Understand? Gallbladder has a typical area where it hangs from the liver. Okay. So if you see the images, the normal anatomy, then you will be able to make out that gallbladder is always visible, just adjacent to the right lobe. It will be hanging down a pear-shaped structure. Okay. So this is a normal gallbladder where you have a stone. It's not normal. Actually, there is a stone inside. This one is acute cholecystitis, where there is thickening of the wall. But this one is a tumor. Why this wall is thickened and it has sort of invaded the liver.
So it's liver cancer.
It's gallbladder malignancy. Okay. So if you see anything adjacent to the gallbladder invading the surrounding structures, then you should think of gallbladder malignancy. Remember, gallbladder malignancy always follows cholelithiasis. So the irritant factor is the gallstone. You see, if the patient has had stones in the gallbladder for over a period of time, they are more prone to develop gallbladder malignancy. That is why it is recommended that you get rid of the gallbladder so that it doesn't turn malignant. Remember, in males, if you have gallstones, you are more prone to develop cancer. So if you have gallstones in males, it is always wise to get rid of the gallbladder. Clear on this, everyone?
Yes.
Good.
Why does it look like it has two walls in the cancer?
You're talking about this?
Yeah, there's
Yeah, because the wall actually it infiltrates the surrounding structure. So you'll not be able to see the entire wall. Okay? We'll see more examples of this. Now look at this structure again. You see the liver is here. Again, it looks like gallbladder area. Why? Again, it's a rounded structure. Now look at this again, the liver. Again, a pear-shaped structure. Compare this with this. What is the difference between this?
There's calcification.
Calcification. So this one is calcified gallbladder. We call this as porcelain gallbladder. Okay? The cause we don't know. Why does it get calcified? Very rarely do we see this. But the potential for malignancy is more in porcelain gallbladder. This is what the stats are. Now if you look at this gallbladder, this has air in the wall. It is known as emphysematous gallbladder. Emphysematous, remember, wherever I talk about emphysematous, it means air. So air inside the wall of the gallbladder. Why do you have air inside the wall? Infection. Gram-negative, E. coli. Okay, so gram-negative organisms result in air inside the gallbladder. This gallbladder is supposed to be infected and it is more likely to perforate. because the wall is now gangrenous. It has air inside. So these gallbladders are more prone to perforate, and obviously these are the patients who must have a cholecystectomy done, because this gallbladder would never turn to normal again. Understand? All that would happen is it would perforate. So it is always wise to get rid of this gallbladder. Similarly, it is always wise to get rid of porcelain gallbladder, because they have more chances of turning malignant. Now this was about the gallbladders. Remember, the liver lesions, some lesions are very easily picked up. Like if you have a cyst in the liver, or if you have a hemangioma, which is bright lesion in the liver, it appears same, more or less same on all ultrasound, CT and MR. But if you have a solid lesion in the liver, then you are in trouble. Then you have to characterize it. Is it benign or is it malignant? So then we have to make use of the contrast that we give in CT and MR. Okay? So on ultrasound, if it's a simple cyst, or if it's an abscess, or if it's a hemangioma, they have very typical appearances. You don't need to further investigate with contrast studies like CT and MR. But if it's a solid lesion, then you have to classify or characterize that lesion. Is it benign or malignant? You cannot leave that alone. And at times, then still if you do not get the answer with the imaging, then you need to biopsy them. Now, this is another ultrasound. This is a lesion in the liver which is hypo or anechoic. Now, if you have jet black lesion like this in the liver, what is this? Enhancement. Shadowing is something black. Remember, shadowing is with the stone. This means enhancement. So when do you see enhancement? When there is fluid inside. So in a cyst, the sound waves are easily going to pass through the water. So you would have enhancement behind the cyst. So this is a simple cyst. Why we call it simple? Because it's jet black. You don't see anything inside. And there is enhancement behind the cyst. So the sound waves are easily transmitted through the cyst, through the water inside the cyst, and you see enhancement like this. You are sure this is a cyst. So you can leave it alone. But what about this cyst?
There is calcification.
Okay, so he says there is some calcification in the cyst. If you look at this cyst, this is jet black. This one has echoes inside, bright foci or bright echoes inside. So these are actually dirty echoes. The dirty echoes is when you have air inside. The air gives you bright echoes like this. There is no acoustic shadowing that you have with the stones. So remember, the air and stones both appear bright like this on ultrasound. It is only the shadowing which tells you whether this is stone or this is air. So these are actually air inside this cyst. So this is an abscess, air containing abscess, and this is all debris inside. That is why it is not clear fluid. So you can differentiate on ultrasound between a simple cyst and an abscess by the appearance or the contents of the lesion itself.
But doctor, then how can you differentiate between calcification and the...
I told you the calcification would be more sort of to the wall, and there will be shadowing behind the calcification. This one doesn't have shadowing. This is all inside the lesion itself. Dirty shadows. We call this as dirty bright echoes or shadows. Now how is this lesion in the liver different from the cyst?
It's full.
It's the opposite. It's called as echogenic. That was anechoic or hypoechoic. This one is echogenic, bright. So this is echogenic lesion inside the liver. When you have a lesion in the liver which is echogenic, you should think of hemangioma. It's a vascular benign lesion. Okay, the commonest echogenic lesion that you should think of when you see appearance in this liver. Remember, the echogenic lesion in the kidney. Have you read kidney with me?
Yes.
So what was that? Angiomyolipoma, the one with fat. So very much similar. If you have an echogenic lesion in the liver, it is hemangioma. The problem is when you have multiple echogenic lesions, then you should think of metastasis. Okay, so the same lesion, this is by the way another case, it's not the same patient. This lesion is quite larger compared to this lesion, but the pathology is more or less the same. If you do a CT scan on the patient with hemangioma, the lesion in the arterial phase, the early arterial phase, will start taking up contrast from the periphery. And if you do